Hello, dear, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of serous carcinoma of the fallopian tube presenting with ascites. So this is a case of a 57-year-old female patient who presented with abdominal enlargement and pain and was found to have ascites, for which she underwent drainage. And this is the preparation of from the ascitic fluid. And as you can see here, this is the Diffquick stain or the Giemsa stain. As you can see, large groups, large aggregates of large cells with abundant cytoplasm and very large nuclei. Now, the cells have a tendency to show vacuolation in the cytoplasm. I'm not quite sure why does this happen, but this is quite common in serous carcinoma presenting or advancing or metastasizing to the peritoneal cavity and having ascites. So serous carcinoma in ascitic fluid tend to show this vacuolation of the cytoplasm, kind of similar to the mucinous tumors, but this is, remember, very common in serous carcinoma. This is the PAP stain, and as you can see, the same groups, similar groups of cells, large cells with abundant cytoplasm that is vacuolated and large nuclei, and here the same, suspicious for malignancy. Now, being female, presenting with ascites, we have to think about female genital tract, in particular ovarian or endometrial carcinoma. And this is the cell block preparation that is very useful to continue on working on cytology, because what we do is that we convert the cytology into a mini biopsy kind of tissue on which we can do immunostain. So this is the same as the ascitic fluid cytology. These are the same groups that I just showed you with the large cells with vacuolation in the cytoplasm and here as well. And then we have the large nuclei with a prominent nucleoli and some tendency at hobnailing. Again, the differential diagnosis would be female genital tract tumors, in particular from the ovary or the endometrium, despite the absence of clear masses in both organs. And this is the immunostain on the cell block. PAX8 is positive. P53 shows the diffuse positivity consistent with abnormal expression or mutant expression, as was P16 beautifully positive. And WT1 was kind of wishy-washy, so part of it was negative, part of it was barely positive. It was difficult to interpret. So the final diagnosis on the cytology was that this is serous carcinoma of female genital tract, probably favoring ovarian because of some positivity with WT1 stain, less likely is endometrial origin. The patient underwent a neoadjuvant chemotherapy and then debulking surgery. And this is the omentum, where we have a large nodule of residual viable tumor cells. And here on the higher power magnification, that is very much similar to the cells that we've seen in cytology, consistent with serous carcinoma. Now, into the origin of the tumor. This is a scanning power magnification of the ovary, and the ovary at large appeared unremarkable, with some benign inclusion cysts, some on deeper levels, just a very small focus of serous carcinoma in the ovary. The rest of the ovary appeared completely normal, not even evidence of a treatment response. So probably this is not the origin of the tumor. This is the same site, fallopian tube, and as you can see, I'm going to zoom in here first and then into this focus. And the focus in the wall of the fallopian tube shows the same ugly hyperchromatic cells with the prominent nucleoli, with the hobnailing. Look at the cell here, we look at the nucleolus here. And this is what we call kind of the serous tubal intraepithelial carcinoma, another focus where we have the tubal lining, and then we have the malignant tumor cells. And here as well, look at how ugly the tumor cell is. This is probably suspicious, but this is not enough to call it a stick. This is the typical stick. And on this slide, I just want you to compare and see the difference between the normal lining, the focus of a stick, and then the normal lining. Remember, in the fallopian tube, whenever you encounter cilia on the surface, regardless of how ugly the tumor cells are, this is normal. This is not going to be malignant. The malignant ones tend to show this rounding of the nuclei, the prominence of the nucleoli, and stratification, hobnailing, in the absence of cilia. This is extremely important to remember. And then we have the focus of invasive serous carcinoma in the fallopian tube itself, showing the same appearance, and the tumor cells are positive for p53. This is the stick part of the fallopian tube, and this is the invasive component. WT1 was not, again, very nice or robust in the stick component, but it was positive in the invasive component in the fallopian tube. Now, the other fallopian tube showed only surface involvement with some residual tumor cells after the treatment, and the other ovary showed only surface involvement of a small foci. What does that mean? It means that neither of the ovaries harbored enough tumor to be rendered as the primary source of the carcinoma. On the contrary, the fallopian tube with the stick and the invasive carcinoma is the origin of the tumor. And this is the endometrium, just to show you that sometimes it can show what we call the hook-nail pattern metaplasia, but this was negative for p53, so this was not serous carcinoma, and just comparison with the normal appearance of the atrophic endometrium. So the final diagnosis in this case is serous carcinoma arising from the fallopian tube as a stick that progressed into serous carcinoma in the fallopian tube and then disseminated to involve both ovaries, the surface of the other fallopian tube, and the omentum with omental deposits, which then led to the development of the ascites. Remember that nowadays the source or the origin of serous carcinoma is actually not the ovary, it's what we call it tubo-ovarian. The origin is actually the fallopian tube. Remember that in order to diagnose a case with a stick, I have to see the cellular features, including the hyperchromasia, the prominent nucleoli, the hook-nailing of the cells in the absence of cilia. Of course, we have to confirm the diagnosis with immunostain, including p53, which shows abnormal expression pattern, either that is positive, strong diffuse, or is negative, completely the null staining pattern. And we have also to supplement this with another stain. In this instance, I did WT1 in order to confirm that the origin of the serous carcinoma is actually from the fallopian tube. Remember that in the ovaries, if the tumor involving the ovary expands less than 5 millimeters of the ovary, this is not considered to be the primary. The ovary is not considered to be the primary source of the tumor. And remember that in ascitic and in acetic fluid, for whatever reason, serous carcinoma cells tend to be vacuolated, reminiscent of cells containing mucin. Just keep this in mind and apply the appropriate immunohistochemistry on your cell block. I hope you find this tip useful in your daily practice. Thank you.